we'll have Durga with the talk comparing IVF outcomes of Progestin prime ovarian stimulation with ultrashort flare GnRH agonist, USF in, poor responders? Sorry, a multicentric randomized control trial.
Thank you, chairpersons, for the introduction. Now, our group decided to actually do a study on the poor responders. In fact, what ESHRE is wanting us to call as low responders, but in the group Poseidon 3 and 4. And this was a randomized control trial that we had conducted. No disclosures to make. And this study was actually done by one of my colleagues called Dr. Durga, but she couldn't be here, so I'm doing this on her behalf. Now, when we are talking about Poseidon criteria, what we are actually starting to see in our clinics nowadays is an increase in terms of Poseidon group 3 and obviously group 4 because of the career choices that people are tending to make and, late marriages and so on. And when we are talking about the incidence, either in literature or in our clinical practice, we are actually looking at the incidence being more than at least 25%. So obviously, this is a group that we need to focus on, particularly because they are coming with low results and we need to make their protocol efficient enough for us to get the best number of oocytes to actually increase the chances of conception. Now, what does ESHRE recommendation say in terms of the poor responders? Like I said, the guideline, which is currently under review, is looking at low responders rather than poor responders. But the one disclaimer against this guidelines is the fact that the recommendations are based on Bologna criteria and not Poseidon. But having said that, let us look at what the differences are between the previous as well as the current, which is under consideration. The difference was that clomiphene, which was earlier said to have a strong recommendation in terms of either alone or in combination with gonadotropins, was equally recommended for predicted poor responders. They are now making it a conditional recommendation wherein clomiphene alone in combination with gonadotropins or gonadotropins alone are equally recommended. The second difference was in terms of the use of progestin for LH peak suppression is probably not recommended. And this was the consideration in 2019, and now they have changed it to if freeze-all is planned, the use of progesterone for pituitary suppression is probably equally recommended, and that's a conditional recommendation. Now, what does the evidence say when we are talking about Poseidon? Like I said, the guidelines are looking at Bologna, but what about Poseidon criteria and what is the evidence that we have? There were two studies that were done by our group itself when we are talking about Poseidon group 3 and 4, and both of these studies were RCTs. And the first one was looking at clomid and gonadotropins versus ultrashort flare, and we found that the mean dose of gonadotropin and duration was lesser in the clomid addition group, but there was no difference in other parameters. Another RCT done again by our group looked at PPOS versus the flexible ANTAC, and here we found that in group 4, there was a higher blast relation with PPOS. So then we started to look at the expected poor responders, that is the Poseidon 3 and 4, and which protocol, that is the PPOS or the ultrashort flare, which offers better outcomes. And the outcomes that we looked at were oocyte retrieval rate, the maturation rate, the fertilization rate, blastulation rate, and secondary outcomes, which included the days of stimulation, gonadotropin dose, most importantly the cycle cancellation rate and the miscarriage rate, amongst others. The methodology was, like I said, an RCT, and we looked for a year in our centers, multi-centers of our organization, and here we looked at about 110 in each group, and there was approximately 11 people that were lost to follow-up, so in total we had about 104 and 105. Now, the protocol was similar to what you would expect in terms of a PPOS, that is, we gave medroxyprogesterone 10 milligrams every day starting from the day of stimulation, which was either day 2 or day 3, as opposed to an ultrashort flare wherein we gave leuprolide for 1 milligram subcutaneously from the start of the follicular phase for 4 days, and we overlapped the last 2 days of the agonist with the stimulation protocols. Now, the inclusion was expected poor responders, and we defined them based on the Poseidon criteria 3 and 4, and it was freeze-all cycles. And the exclusion, as you would expect, hypos, the premature ovarian insufficiencies, uterine malformations, etc. Now, coming to the results, the statistical analysis was done using SAS 9.4 with a P4 value of less than 0.5, considered statistically significant. Now let's look at the baseline variables, and here the PPOS surprisingly were younger in age, and the BMI was lesser as compared to the ultrashort flare. Now coming to the primary outcomes, here what we noticed was the oocyte retrieval rate, the maturation rate, and the fertilization rate were exactly similar. But the difference was in terms of blastulation rate, which was significantly higher in the PPOS group. Coming to the euploidy rate, because this is another thing that concerns us, particularly in Poseidon group 4. And here we found that the euploidy rate was similar, irrespective of the protocol that was done. Coming to the secondary outcomes, the days of stimulations were lesser. The gonadotropin dosage was lesser in the PPOS, which makes the ovarian sensitivity better with this protocol. Now, the secondary outcomes in terms of the cycle cancellation rate was similar. Follicular output rate, the FOI index, utilization rate were all similar. And what was also important to note is that the premature LH surge was not seen in either of these two groups. Now, coming to the implantation rate, similar. Clinical pregnancy rate, similar. Very importantly, miscarriage rate. And the reason why I'm focusing on the miscarriage rate is there were some earlier studies which said that with PPOS, there was slightly higher miscarriage rate. But the multiple pregnancy rate, and for our study, we looked at the ongoing pregnancy rate, and that was similar too. So what are we trying to say? Based on our study, the blastulation rate was significantly higher in PPOS compared to the ultrashort flare. The euploidy rate was similar. PPOS had a significantly less doses of gonadotropin requirement, as well as the duration was slightly lower, which made the ovarian sensitivity index higher. Cycle cancellation rates are similar, but again, we are talking about poor responders. So what we noticed was that the cycle cancellation rate in both these groups was approximately around 10 to 12%. There were no cases of premature LH surge in either of these arms, but progesterone tablets are obviously cheaper. Women like it rather than having more injections, and therefore there's more compliance and less dropout. So ultimately, our conclusion was it works well for expected poor responders. We noticed better embryological outcomes, obviously patient-friendly, like we already discussed. It's obviously less expensive, and it seems to perform slightly better than the ultrashort flare. But the only thing is, yes, when we are looking at progesterone protocols, we are looking at freeze-all cycles. So here the discussion could be that by saving money and giving tablets, are we actually making the cycle cheaper? Because obviously for going for a frozen embryo transfer, it will require additional expenditure. What are the limitations of our study? It was a single blinded RCT. We are calculating the live birth rate, which hopefully we should be presenting very soon. And this was obviously a limited sample size, but we are continuing the randomization still. Thank you very much.
The floor is open for our discussion. Yes?
Yes, to the right. The microphone.
Did you transfer fresh in the flare protocol and frozen in the PPOS, or both frozen embryo transfer in both groups?
Both groups were frozen embryo transfers.
And both groups were also PGTA?
No. PGTA was done in selected number of people who chose to have PGTA, but the ones who had PGTA on both the protocols were similar, but it wasn't done for all.
Thank you.
Was this patient given any pre-treatment?
No.
Thank you.
Please state your name and country when you ask a question. Any other questions, please? Can I ask you something while
Sure.
people are probably gathering their thoughts? This is a randomized controlled trial.
It is.
What was your primary outcome, and did you do a power analysis, a sample size calculation?
So the power analysis was approximately, when we did our calculations, it was 70%. I agree that ideal is about 80% but then when you're looking for power calculation, but the significance was approximately 5% with a power calculation of approximately close to 70%.
What was your primary outcome?
The
What
primary
was the study
outcome
power
that
to detect?
we were actually trying to detect at least a 10% difference in terms of blood stimulation rate, which we did.
And that blood stimulation rate, how was it calculated? Was it calculated per patient randomized, on an intention to treat basis?
It was on intention to treat basis.
Yes, Suzanne from Germany. Thank you for your talk, but can you explain to me the follicle outcome like 102%? What is 102%? If you do a pickup, 102%, I can't understand. And can you explain, secondly, the pregnancy rate of 69%? I can't understand. If you don't do PGD, I don't understand.
Okay, let me explain what 102% is. When we are talking about follicular output rate, sometimes the number of follicles that you're tending to see at the baseline may not always be an accurate assessment, because obviously there will be some interpersonal variation, and you're looking at a baseline. When we are talking about 4, we are looking at AFC, we are not looking at the follicles there, correct? So your denominator is AFC, and that's the reason why you would have something more than 100%. And what was your second question, sorry?
They were querying how come in
Pregnancy
poor
rate.
prognosis patients you have a 69% pregnancy rate when not everyone has done PGD.
Not everybody has PGD, but we completed, this was a combination of everybody. This wasn't, we didn't segregate PGD, we just looked at uroidy rate, which is what we told you.
You don't have the pregnancy rate with PGD at 69%. If you do every time PGD and you have 69%, it's fine.
It is high,
Don't do.
and thank you for the compliment, it is high.
What was the proportion of PGTA in your patients?
Sorry, what was the?
The proportion? How many?
So probably the Poseidon group 4 would be higher, because our protocol says that our, anybody crossing 37 is who we offer PGT to. Obviously the women are, given the choice should they want it, but we offer it more to women who are crossing 37. And your question was what was the percentage of proportion? Well, when we're talking about Poseidon group 4, we had more than 50% of them choosing PGT versus approximately 20-25% in group 3.
Okay, and we have one last question.
Ben Monash Melbourne. So one disclosure, I had a heart attack in India in December, and your colleagues took very well care of me. So I have a stent from India, so India is always in my heart. Thank you.
We're very hospitable, thank you.
Thank you. My question is, did I understand it right in your last sentence that you continue to randomize?
Yes.
Okay.
Because, like we were talking about the power of calculation, and when we're talking about, the significance, so we are ideally looking at close to approximately 300, and that would give us the right kind of power and the significance that is required for at least a 10 to 15% difference.
I mean, my education in clinical epidemiology tells me something else. I have sympathy maybe for submitting an abstract with the pregnancy rates and then collecting the live birth rate later, but I think if you're still randomizing, you should not analyze your data at the same time, but for your data safety monitoring.
So we always tend to do an interim analysis, and that is to let us know whether the course that we are actually taking is the right one or not. So that, and there are certain trials that get stopped with the interim analysis.
And was this interim analysis pre-planned? Is it in your registered, do you have a registered protocol
Yes,
where you
this was
describe
a registered
interim
trial,
analysis?
and we have an ethical committee approval as well. Yes.
And in the protocol it says that you will perform an interim analysis?
that is, I wouldn't say that is in the protocol, but we did sort of have a look at it.
Thank you.
We still have very short time for one question about the Ultrashort flare protocol.
Mm-hmm.
Did you mention that you use antagonist?
Yes, I did.
So what was the protocol? Because usually Ultrashort protocol you use the agonist along the cycle.
So that is the short. What we did was the Ultrashort. So we gave 4 days of loop, right? And the last 2 days were coincided with the stimulation, and we did the antagonist as a flexible antagonist.
Yeah, but don't you think that the main way to suppress LA surge in this protocol is the antagonist?
Yes, I would agree.
So is it fair to call it an ultra-short flare agonist protocol, as if the suppression is happening with the agonist?
It is happening with, I wouldn't call it an ultra-short flare agonist protocol. I would call it an ultra-short flare protocol.
Thank you, sorry,
Thank you.
the time is done.
Thank you very much.
Thank you. Thank you. And now I would like to welcome and ask the second speaker,